Good afternoon, everyone, and welcome to our webinar on cancer care after COVID. This webinar is brought to you by the Longevity and Mortality Actuaries member IMPAS Group on behalf of the IFOA's Mortality Research Steering Committee. My name is Daniel Ryan, and I'll be your host and moderator today. Just a couple housekeeping points. So first of all, the recording of the entire session will be made available tomorrow. And on the right of your screen, you will see hopefully a chat function. If you'd like to ask a question of any of the panelists, please do so, and we'll try and address it during the course or indeed towards the end. So in previous webinars, we've tended to look at wider effects of COVID-19 pandemic on mortality and longevity, but today we're going to focus on cancer. And from the very start, the aim of these webinars was to reach outside of the actual profession so that we could share and learn from expertise and experience of other professions, and helping us through understanding the immediate and longer term effects of disruptions to diagnosis and treatment. We are very lucky indeed. Well, we'll be incredibly lucky if we get all three presenters, but we're very lucky to have three panelists today. Let me introduce all three of them. So first of all, Caroline, who hopefully will be able to join us, Dr. Caroline Chill, is an experienced GP who has been clinical director for healthy aging at the Health Innovation Network, the academic health and science network for South London for the past 5 years. She was a GP principal in Merton from 1988 to 2012, and now works as a freelance GP as a member of the Pallant Medical Chambers. She has held leadership roles as a clinical director for older and vulnerable adults, community services, primary care, and unplanned care in Merton CCG. Since the start of the pandemic, she's been involved in supporting care homes with projects including use of shared urgent digital care plans, identification of deterioration, and remote monitoring of residents. Our next panelist is Dr. Chris Martin. Chris is a former general practitioner and health informatician with a MSc and PhD from the Centre for Health Informatics and Multi-Profession Education at University College London. He is specialised in cause of death and risk factor-based mortality and longevity modelling to support healthcare decision-making at the clinical and policy level for over 20 years, and has worked in the pensions and insurance industries since 2008. And completing the panel, we have Nicola Oliver, who will be well known to many of you in the audience through her founding role on the COVID-19's Actuaries Response Group and a large number of working parties for the Institute and Faculty of Actuaries. Nicola has been providing valuable insights into the medical and social demographic elements that impact mortality, morbidity, and longevity risk to support clients across the insurance industry since 2012. Before, Nicola's background included a long career in the NHS, firstly in intensive care and latterly in public health. So I'm delighted that all three of you are now present. Apologies, you may not have heard all the introduction, but let's start and crack on with some questions. Starting off, we've heard so much about how the pandemic has disrupted cancer care, but before we get into that, perhaps we would benefit from casting our minds back before the pandemic and looking at the state of cancer care in 2019 and the types of changes that were being made. I wonder, Carrie, would you mind kind of sharing some of your thoughts on that?
Sure, thank you. 2019 seems an awfully long time ago now, but my recollection from a clinical perspective is that we had a well-established 2-week WAPE pathway, that targets were largely being met and that screening uptake was increasing. I looked at some NHS digital figures for 2019, and there were about 327,000 new cancer diagnoses, so around 900 a day, and that was 3,700 and something or other more than 2018. Rates of diagnosis were higher in the most deprived populations, and rates of cancer deaths fell by 1% in men and 2% in women in that year. So things were looking fairly positive before the pandemic.
I didn't
Sorry,
hear
Daniel.
you. I think you're muted.
Sorry,
Dan.
apologies. I'm muted. Yes. Chris, anything further you'd like to share on that state of where we were?
Yeah, I think it's probably worth looking at how the UK performed in terms of cancer care internationally. And I think your first thing to say is the UK is a wealthy, developed country, and so the survival, is pretty good comparatively. However, if you start looking within the group of wealthy, developed nations, the UK performance metrics tend to trail around the back historically, and there's probably three explanations for this. Firstly, there's probably some genuine effect, particularly around the speed of diagnosis and presentation, and how that leads into later presentation and worse outcomes. But also, the data does need to be interpreted with care. There are different, the organisation of healthcare in different countries is different. It's, thankfully, it's largely universal in the majority of developed nations now, with perhaps the exception of the US. But they're different systems with different incentives. And so, for example, if we take the example of prostate cancer, where prostate cancer, there's a large body of prostate cancer which is actually relatively indolent and not really clinically significant. The rule of thumb is that half of men over 50 have prostate cancer. It's just that the great majority don't know it. And so if you go looking for it, you'll find it. And in the States, they're quite aggressive in doing that, with the result that the denominator when it comes to survival tends to be inflated with effectively clinically insignificant cancers. The other effect is around data collection. One of the advantages of being in a centralized universal healthcare system like the NHS is the data is pretty good in comparison, particularly around completeness. Again, making a comparison with the US, if you're not insured or you've got inadequate insurance, you don't get diagnosed and you don't get onto any registers, and so there may be a skew towards wealthier groups with lower mortality rates in that sort of healthcare system. But that doesn't get away from the truth, I think, which is there is an issue with late presentation of cancers historically in the UK.
Thanks very much, Chris. That's very helpful indeed in kind of setting the scene. And maybe now moving on to obviously what's happened in the last 2 years. There are many different areas we could look at, but maybe we can start by focusing on the healthcare system itself. And Nicola, I wonder if you wouldn't mind sharing your perspective on how the delivery of cancer services changed during the pandemic, and maybe what rapid learnings and adjustments were made.
Sure, thanks, Dan. So, ironically, just before the pandemic, or actually in 2021, some faster diagnosis pathways were introduced, such that there across the whole cancer pathway, there were targets that were set from a 2-week wait perspective through to the long-term 62-day target, which is from initial presentation in primary care right through to the start of treatment. The infrastructure was put in place to try and deal with that kind of development. As a consequence of the pandemic, of course, we had initially the cessation of some screening, or most of the cancer screening programs, and these are going to take some time to catch up. We know that during the first year of the pandemic, around about 1 million people about 1 million fewer people were invited for screening. And I'm talking about the population-wide screening programs such as breast cancer screening, cervical cancer screening, and some of the aspects of the bowel cancer screening program. We don't have in the UK any other population-wide screening programs. Any other kind of cancer screening is on a sort of as-need basis. So we know that screening programs have certainly been working above their usual levels since then to catch up. And that in fact, people who need treatment following screening, and this is something to be positive about, is actually 10% higher now than it was, 10% higher in November of last year than it was pre-pandemic. So that's a sort of overview of how quickly people are catching up. However, waiting for a key diagnostic test, we still have many thousands of people waiting for that. And the type of diagnostic tests I'm talking about would be things like an endoscopy, so a camera down the throat to look into the stomach, for instance, and some of the radiology diagnostic tests such as MRI, CT scans, non-obstetric ultrasound, that type of thing. And according to sort of reasonably latest analysis, there were something like 10 times more people waiting 6 weeks or more for that diagnostic test compared with November 2019. And it's pretty much the highest number on record for those waiting for radiological diagnostic tests since records started in 2006. So what does that actually mean? And I think we'll probably explore this in a bit more detail. But at the very latest, as we know, later identification of a cancer will result in a poor prognosis, unfortunately. So if your screening is delayed, there's a chance that obviously your identification of any risk of cancer is delayed, because that's all that screening really is. Then if you're delayed then further for your diagnostic test, then that could also move you, for instance, from an earlier stage cancer into a later stage cancer. There's another area of concern is of those people who just won't bother to come back at all. So this sort of missed population that is something that we have to be mindful of. So we're certainly looking at huge numbers of people waiting to be seen and waiting for their first diagnostic tests. I know that the NHS is working really hard to try and catch up with that, but that's going to be one side of this pandemic that is going to cause concern.
Thanks very much, Nicola. I wondered, Carrie, do you want to share anything more on that which has already been shared so far?
Sure. I think it's a really good point about people being frightened to come forward. And certainly there was a perception early in the pandemic that all services had stopped and that primary care had closed its doors. But in reality, 2-week rural referrals never really stopped and carried on. But I think many people were just frightened of coming to a health service or frightened of going to hospital. I had a little look at some Macmillan data for the screening services, and certainly many fewer people for breast have been screened in the last 3 years. And there are fewer people who've responded to invitations to screening within the last 6 months. Interestingly, for cervical screening, which is largely done in primary care and which was paused for most of the pandemic, there's been very little change in the 25 to 49-year-olds, but the 50 to 64-year-olds really have not been coming forward, and there's a very significant drop-off in them. But relatively little impact to the bowel screening program, and that may be because it was a sort of no contact fit testing, stool samples, and people were perhaps more confident to carry on with that.
Thanks, Carrie. I mean, you've introduced, I think, very clearly, this concerns on the part of individuals coming forward, and the impact that has in terms of delays. I wonder, Chris, do you want to talk a bit more about that particular area and what we know and what might actually be done about it?
There is the stage at presentation is key here, and if we can look at registry data to get an idea of the scale of the impact of that. So if we take breast cancer, for example, the difference between in the 5-year survival for those who present with a regional cancer, and that's where the cancer has spread to perhaps the local lymph nodes or just directly by growing, and compare that to just a localized cancer, there's an 8% drop, modest 8% drop in 5-year survival. On the other hand, if you look at distant cancers that are presenting with distant spread, metastasizing to bones or brain or whatever, there's a 68% drop in comparison to the regional spread. Similar figures for lung, the difference between regional and localized is about 27% fall, and a 60% fall for distant to regional. Interestingly, prostate cancer, there's no difference between regional presentation and localized. Essentially, the survival rate is excellent in both groups. Big difference though with those that present with distant spread, where there's a 60, more than 60% fall in survival between the distant spread and the regional. And this probably reflects this sort of dichotomy in prostate cancer between the clinically insignificant group and this subgroup of aggressive rapidly spreading and lethal cancers.
Thanks very much, Chris. I wonder if we could just go back and explore a little bit more some of these worries of the patients. Nicola, is there anything you wanted to kind of add to that?
Yeah, thanks, Dan. So as Carrie quite rightly mentioned, people are very nervous about coming forward, and there's some evidence to suggest that this is a population of probably hundreds of thousands of people, and I think we have to compare, probably going back more than just the last couple of years, the rates of people fronting up for their screening, because it does ebb and flow. It certainly ebbs and flows in relation to what might be happening in the media, for instance. One area, not in cancer care, but we know that there was a huge decline in, for instance, presentations to A&E for people with chest pain, for instance. Another area is to look at how people are actually being admitted to hospital. So we look at the pathways that people being diagnosed. We can look at the pathways to diagnosis. There is a little bit of evidence there is a high rates of diagnosis via emergency care. So this also indicates that people are perhaps a little bit more nervous about presenting, and that they are actually perhaps waiting for more severe symptoms to turn up. I mean, I wonder, Carrie, if you have any sort of more anecdotal or direct insights to what people might be saying about the fact that they don't want to have screening, or they're worried about presenting at hospital, because I think it's really useful.
Yeah, I think the worry is one part of it, but I also think that the rapid pivot of health services to sort of digital and remote first services, as opposed to kind of just walking in and seeing the doctor, has potentially introduced some inequalities for the older population and those that are somewhat digitally excluded. And I think perhaps they've just found it too difficult or too complicated, together with the use of hubs where practices were coming together to prioritize COVID cases and urgent cases, has perhaps put parts of the population off and confused them in terms of the pathway of care. Increasingly, first contact, even after referral for cancer, may be digital or by phone, and some people are just not understanding that change, and then not following up with their further tests and investigations. Anecdotally as well, I am also coming across an increased number of 2-week rule referrals being rejected because a box hasn't been ticked, or a pre-referral investigation hasn't been done because it isn't accessible at the moment, or the waits are long. So I think there are issues across the whole care pathway.
Thanks very much, Karen, and obviously following on from Nicola's comments. So far, we've been talking more from the patient dimension or patient experience, but obviously the healthcare professions and healthcare systems more generally have had to continually change throughout the pandemic under enormous pressure. I wonder, Carrie, could you kind of talk a bit about, what you think the result of that level of pressure is going to be in terms of, people in the profession and further change there may be in terms of cancer care in particular?
That's an interesting one. I think it was quite surprising very early on in the pandemic how positive people were and how the professions came together very dramatically. A lot of the kind of rules and regulations were shelved, and everybody just rolled their sleeves up and worked together for the benefit of the patients. And that created a sense of togetherness and well-being. And despite the fact that things were very, very tough, I think people felt that they were doing the right thing. Gradually, the kind of governance and requirements have been leveled back on. And I think the healthcare and social care staff are pretty exhausted. I think they're feeling pretty undervalued. I think there's been a media campaign that hasn't been particularly positive to how the health service is doing. And I fear that there are going to be a lot of people choosing to retire earlier than perhaps they might have done, or work fewer hours. And that, together with a general workforce shortage, is making things pretty difficult at the moment.
Thanks, Carrie. Really appreciate that. Chris, I wonder your perspective looking from where you are.
Yeah, so I no longer practice clinically. I was a GP until the end of 2017. I did, and I'd have to say you could tell the morale was beginning to wear out a bit at that point, with essentially the thinning down of resources in primary care in particular. But I volunteered. I joined the medical workforce during the pandemic, and helped man the COVID advice lines through 2020, and the morale was actually quite high. People just wanted to get on and help, and that created a bit of a buzz, but it did wear thin, and I no longer. I've stopped doing that, and I'm no longer clinically active. However, speaking to colleagues, their morale is very low. A recent poll suggested that more than half of GPs feel that morale is very much worse than it was prior to the pandemic, and it was. Let's be frank, it wasn't good before the pandemic, and it's very poor now. How does this translate into people leaving? In April 2022, there were more than 1,500 whole-time equivalent trained GPs fewer than in 2015. Over the time of the pandemic, there are about 400 fewer whole-time equivalent GPs than there were before the pandemic. And I think that's likely to accelerate. I think people hung on through the pandemic because you don't quit when people are in trouble and depending on you. But I think there's now going to be a bit of an exodus. Nursing, I've got less insight into that, not having been a nurse. But in 2019, the government did commit to recruiting another 50,000 nurses by 2024, and they look on track to be doing that actually. So there's been an increase in the number of nurses, but the number of nursing vacancies has risen by about 5,000. So I'm not sure what's wrong with the numbers here somewhere, but we're more deprived of nurses now than we were before the pandemic. Despite this apparent increase in numbers.
Thanks very much, Chris.
I think I'd just add a couple of observations to that, Dan, if I may. I mean, the nursing workforce crisis has been, as Chris said, across the board, something that's been going on for a while. And there's a couple of, I think there's a couple of other explanations as well, not just the fatigue of the pandemic, but we mustn't forget the impact of Brexit. And a very key part of this is the cessation of grants to prospective student nurses. This was access to higher education through this route was a very good prospect for many young people. And now the way that you access nurse education is through the same as any other degree. The grant was initially in place because historically student nurses were as part of the workforce, very much so. So you were a small salary or bursary was something that was certainly part of that. So the number of young people accessing nursing to begin with is also dropped. So we've got a bit of an unfortunate perfect storm of events that have led up to this crisis.
Thank you very much, Nicola. The last webinar,
and similarly, that impacts social care. Obviously, Dan, that, similarly impacts social care, particularly in Brexit has certainly impacted that. Unfortunately, it tends to be a lower paid role. That's unfortunate, and in many ways we could argue ethically it shouldn't be, but a huge amount of the workforce came from the wider part of the EU. For many reasons, many workers felt that they were unable to continue working and left. And so that social care that impacts what goes on in hospitals, because of course you may end up with some bed blocking, not enough social care support staff, it creates a larger problem.
Cara, given your kind of areas of expertise, do you want to kind of talk some more about the kind of impact relating to social care?
Yes, and I think everything that Nikki has said is absolutely spot on. I think in order to have a decent flow through the system, people need to be able to be discharged into care settings and supported post-operatively and socially if they're older and frail. And there are major issues with recruiting and retaining staff in the social care system. There have been political musings as to how this will get fixed and an increase in national insurance. But as I understand it, the majority of this is going to the health service at the moment. And I don't think we've fixed the social care problem at all as yet. I think it's also important to remember that a large proportion of social care is self-funded and means tested. And sometimes people just don't wish to spend their money that way. So there can be problems actually even getting social care if they can afford it.
Thank you. That's really helpful indeed. I wonder if we could, returning kind of primarily focused around cancer care, we've obviously had a number of different perspectives on different threads relating the patient, the health workforce. Whether we could kind of paint a bit of a picture as to effectively what may happen over the next 5, dare we even say longer than that. And I wonder, Nicola, would you mind starting painting that picture for us?
Yes, Dan, no worries. I mean, I think we've sort of set the scene in terms of several things here. Are we going to see an upstream migration of staging at diagnosis? As Chris alluded to earlier, we know that later stage diagnosis leads to poorer survival, and even looking in particular even at longer term survival rates. I mean, breast cancer is almost, even 95% of people diagnosed with breast cancer across the stages, I might add, are found to still be alive after that time. And stop breast cancer, bowel cancer, prostate cancer, very eminently able to be theoretically not cure. We wouldn't use the word cure, but we would say that the early treatments lead to a very, very good outcome. So number one, are we thinking about a future where some of the cancers that previously had a larger diagnosis rate in the early stages move up to the later stages? And to address that, will we see a changing health system that can actually offer these kind of screening programs much more centered around how the patient can get to them, rather than expecting people to travel particularly far. Secondary to that, I think if we're looking at things like the way that we managed to investigate treatments, and in particular I'm talking about the vaccines for COVID, which were rolled out very, very short notice, and I'll kind of hone that in a little bit further and talk about the mRNA vaccines. Now, this type of vaccines, this type of technology has actually been under investigation for treating cancer for a long time. It's just that the labs that were investigating these type of therapies adapted their approach to be able to develop the mRNA vaccines for the SARS-CoV-2 vaccine. So at the moment, there are quite a number of clinical trials in place. I mean, in fact, looking at the last thing, there are a number in clinical 2 and 3 phases, including those to look at malignant melanoma, breast cancer, other types of, let me have a look, triple negative breast cancer, prostatic neoplasms. So there is a sort of positive coming out of this. So if these vaccines will work in a way where they're able to instruct your body basically to make antibodies sufficient to go after a cancer cell in the very basic forms, because of course with cancer, many things are happening to develop the cancer, but if we can actually harness your immune system more readily to deal with it, then that's a positive. It's more of a tailored treatment. It's less, potentially has much less side effects. So will this mean that even in the next 5 years that we are developing an mRNA vaccine for cancer? Now, that's not to say a vaccine that prevents cancer to begin with. It's something that can be used to treat cancer in its very early stages, like I say, by using your own immune system to actually tackle that. I mean, cancer development is really rarely an isolated event, so various things come into play. But this could certainly be, this is something that scientists have been looking at for some time.
Thanks, Nicola. Fascinating what may be one of the spin-offs, if I can put it that way, from COVID in our benefit. I wonder, Chris, kind of adding to the picture of how you feel cancer care may develop over the next 5 years, what you might add.
Well, I think the first thing to say is the next few years, I think, are going to be dominated by playing catch up and perhaps seeing a cohort of people come through at a later stage, which is going to kind of shift the balance of different therapeutics being employed. Once that's done, I mean, there is a program of a catch-up program which involves the setting up of surgical and diagnostic hubs, for example, or in greater use of IT and technology to organise the workflow of people through the system. And I think, whilst this is intended to be temporary, it's hard to imagine that we aren't going to learn from that, and that we could see some permanent changes in how we're organised around earlier diagnosis of cancer. So I wouldn't be too surprised to see persisting surgical and diagnostic hubs continuing in some form or other. And in terms of the therapeutics, perhaps less related to COVID itself, I think we're going to see more use of genetic testing. It's now cheap and easy to sequence a genome, but thus far we haven't really understood how to use that information effectively in cancer care as in other areas. And I think there is a lot of research going on to try and clarify, how do we use this new tool. Targeted immunotherapies is, as Nicola was saying, is probably the other big area of therapeutics that's going to become more obvious, and that either as targeted monoclonal antibody immunotherapies, or more specific things like CAR T. And I think the last area of hot research that's going to have an impact is probably data exploitation. We now have huge amounts of data and greater computing power, and I think the development of effective diagnostic, prognostic algorithms for identifying people at risk, improving the diagnosis, optimizing treatment. These are actually, in the first instance, data analysis exercises to try and work out the optimum ways to do these things.
Thanks, Chris. That's a really helpful kind of overview. I noticed, Gary, you were nodding your head very vigorously on a number of occasions. Please do share some of your thoughts.
Yeah, I was just really nodding my agreement with what's been said. I absolutely think that rapid access diagnostic centres will expand and persist. And I think there will be a greater focus on personalisation of care. So using genomic testing to identify the best types of treatment. The government's ambitions document for cancer says that by 2028, that the aim is to have 75% of all cancers diagnosed at stage 1 and 2. And from where we're sitting now, that feels quite ambitious. And I wonder whether that could result in the sort of issue that was being referred to earlier around identifying cancers that may be pussycats rather than tigers, and a risk that we may start to overtreat some cancers which are incidental and relatively benign whilst chasing targets. And I think we need to be very cautious of that and cautious of how we use AI and some of the automated techniques to ensure that we do good rather than harm.
That's a very important point, and clearly easy to get carried away with the potential to detect this kind of continual balance between cost and benefit to the individual is paramount. Just a kind of reminder to those listening, please, if you have any questions that you want to put to the panel, just type them into the chat under the all, and we'll be able to see those. So far, we've taken very much a focus, quite rightly, given expertise and knowledge in the UK, but there clearly have been a number of studies going back in the past, such as Concord, which have shown or demonstrated how different cancer detection, cancer survival, and mortality can be in different countries. Given the global nature of the pandemic, I wonder, Chris, if you wouldn't mind starting, any particular insights that you might have in terms of particular countries that may have coped somewhat better in terms of cancer care during the pandemic?
Yeah, I think that's the $60,000 question. I don't think anyone's in any position to say at the moment, because the data's still coming in. What I can say is that there's a confederation, for want of a better word, called the International Cancer Benchmarking Partnership. This is a collaboration of different organizations in different countries, with the aim specifically of comparing cancer care in different countries and their relative performance, with the ultimate aim of finding the best practice internationally and disseminating it. And they have actually started a COVID impact research stream. There's no reporting from that as yet, but I would imagine in a year or two's time we'll start to see data coming through on how different countries how different countries reacted to it, how the different kind of solutions, on what was and wasn't successful. But at this stage, I think it would just be speculation.
That certainly sounds very interesting, and we'll wait with kind of bated breath to see what kind of research is presented on that platform. Without wanting to force you to speculate, is there any further things that you might want to share, Nicola, in terms of this international dimension?
Yeah, I think we have excellent data, like say Concord, and there are other data sets that have helped us understand where we are in terms of a comparison between the UK and other countries. Interestingly, it's not always the countries that throw the biggest amount of money at this problem. It's often to do with patient education, patients who are willing to present themselves earlier. So, for instance, we know that, just off the top of my head, that certain countries in Europe do certainly an awful lot better than us, and the US survival rates aren't any better as a result of an increased GDP on health. So you kind of have to, obviously we have a different model of medicine altogether, as is at point of need. I wouldn't want to completely speculate on who's doing better. And as Chris said, I think we need to wait for, I mean, any kind of survival analysis really is going to take time. And I know that certain parts of Europe are also playing catch up with their screening, France and Italy for sure, but they still approach the way that is done very differently to the UK. And this is a problem that we have. We don't have standardization of how screening is offered and how diagnostics are offered. So that's a really long-winded way of saying I'm a bit on the fence about that.
Thank you very much for dealing with a difficult question. I noticed we've got a couple of questions there, so I'm going to read them out just in case people don't see them on the chat, and then leave it up to the three of you who might want to kind of come in and answer those. So the first question is from Murray, and it's, what might mRNA cancer vaccines mean for claim rates on critical illness policies? Would they prevent cancer reaching the severity level required for a claim, or is it more likely that they only get prescribed after the claim threshold has been met?
Okay, interesting. So the claim threshold, I guess the need to understand the claim threshold. Is that, I mean, these vaccines, are, from what I understand, will only be administered after a diagnosis of cancer. And so would that already mean that the claim threshold has been met anyway? In terms of survival, I don't think it's going to prevent cancer reaching the severity level required for a claim. That would be my sort of gut reaction right now. I don't know if Chris has any different view on that.
No, I'd agree with that.
Yeah, it's this is like I said, this is not going to be a vaccine to prevent cancer. Yeah. It's going to be used as a treatment in early stage cancer. So yeah, I imagine that that's not going to be the case.
Yeah, I mean, that seems, I mean, where there are thresholds, they're normally related to when something is detected pre-symptomatically. So the extent that there may be some kind of early screening and then treatment thereafter, then I guess it's going to depend on which country and where those thresholds are. But yeah, that's very helpful. Another question from Stephen. Given the pressures on NHS staffing mentioned by the panelists, plus the fiscal constraints arising from the pandemic limiting the ability to inject cash to aid the catch-up programme, how concerned are the panelists that we may see a lost generation for cancer care, whereby we see a whole generation missing out on screening and so having materially elevated cancer mortality over the next decade?
I'm not that worried, actually. I think the numbers who haven't come forward for screening are less than I might have anticipated. And I think catch up in the screening programs will be possible, although there may be a small delay. I think some of the staffing issues will probably be mitigated by different ways of screening. So it may well be that self-taken cervical samples can be used moving forward, and bowel screening is self-taken. And I think those things will encourage people to come forward. I think the point about cost and staffing for cancer treatment and delays after people are diagnosed is more of a worry to me, actually. But I suspect that cancer will almost certainly be prioritized over other conditions because it's politically very sensitive. And I also worry about delays in non-malignant conditions, which can be equally as fatal.
Yeah, I'd agree with that. I mean, the screenings in relative terms is cheap and very cost effective, and I have no particular concerns that that's going to decline, and is likely to expand as we improve identify more effective screening testing. What the elephant in the room here is that we may be on the verge of a really nasty recession. And that is inevitably going to have a bad impact on health outcomes. Screening may be one of those areas least affected, I suspect, because it's relatively cheap and effective. It's the treatment and therapeutics and the speed with which we treat people is going to start to have an impact.
Thank you, Chris, and Carrie, for that. Very helpful. I want to take a slightly different angle, if I may, slightly provocative. But we've been talking predominantly about these disruptive indirect effects of the pandemic on cancer care. And so far, something like, I think the OMS is saying something like 75% of the UK population has been infected at some point with COVID, and obviously very worrying numbers of people are suffering from the symptoms related to long COVID. I wonder the panel's thoughts on whether COVID may have any direct effects on the cancer incidence and obviously subsequent thereafter. I know it's very provocative, but I wonder, Carrie, a little bit of speculation on your part.
Yes, I think it's really interesting. I think it will be some time before we know whether COVID itself is an oncogenic virus. It's possible, but I think it's relatively unlikely given that other coronaviruses are not at this point. However, a proportion of people who've had COVID pneumonia do develop lung fibrosis. And I wonder whether that might result in either an increase in lung cancers or a delay in diagnosis of lung cancer due to the fibrosis. I think the other thing that is relevant is that we obviously know that COVID is a thrombogenic virus, and therefore it's bound to have impacts on cardiovascular health in the longer term. And certainly for older people living with frailty, people are beginning to estimate that a bad bout of COVID could add about 10 years worth of frailty to someone's well-being. So it definitely does reduce longevity, or is likely to reduce longevity, but not necessarily from the cancer perspective.
Thanks, Carrie. That's really helpful and somewhat daunting in terms of the impact that it would have in terms of frailty. I wonder, Chris, do you have any thoughts as well in this area?
Well, I might take a slightly different view to Carolyn on the. I mean, I really hope that COVID doesn't have any oncogenic tendency. There's probably, and to be sure, when we say oncoviruses, the relationship between the infection and the outcome of cancer is not necessarily very strong. The commonest, probably, that we're all familiar with is Epstein-Barr virus, the glandular fever virus. Virtually everybody has that by the time they're 21. But there's a definite association between nasopharyngeal carcinoma in the Far East, Burkitt's lymphoma in West Africa. So it's obviously a small minority. It's obviously a cofactor with perhaps some other environmental or other infective cofactors increasing the risk. So that's the first thing to say. It's not necessarily a very large effect. So there's probably an awful lot of viruses with a small effect on the risk of cancer that we're not really aware of. The thing that worries me about COVID, even in comparison to other coronaviruses, and this may be because it's a novel coronavirus in humans, and this may change going forward, but it's been a multi-system inflammatory disorder, and yeah, things that cause inflammation in lots of places, you know, it may increase the risk of cancer in different places. But you know, at the end of the day, only time will tell, and unfortunately, the time scale we might be talking is 20 years, you know, a couple of decades, you know, before we know whether it does or it doesn't.
Thanks very much, Chris. Appreciate that. Nicola, is there anything you wanted to add on that particular thought?
I don't think so. I mean, I think I echo exactly what Karen and Chris said, particularly around the lung cancer perspective, that fibrosis of the lungs, we know, certainly could play a role. From the point of view of a chronic inflammatory picture, and it's well understood that chronic low-grade inflammation certainly has a role to play, not just in cancer, but in heart disease and possibly other chronic conditions. So is that going to be a problem? There are some sort of small hypotheses around tumor suppressor proteins that may well be damaged by the effect of the virus. And again, this is something that's just a hypothesis, but people are really thinking about pro-oncogenic effects of this virus. So that obviously the most significant contribution that we're talking about is the indirect effects, but will there be direct effects? Time will tell. There's enough sort of small theories to suggest that there could be, but as I mentioned previously, the development of cancer is a sort of multifactorial event. It's not just one particular pathway that's going to kick things off. Obviously, we have the ability to deal with any constantly mutating cells in our bodies anyway, and so this is a one-off event, not likely, but in tandem with other carcinogenic drivers, that's something that we would have to be thinking about. Purely speculation at this stage, but I don't think it can be completely ruled out.
Thank you. I appreciate you all indulging my kind of speculative question. I notice we have one other question from the audience, and that's from Amy. I'll just read it out. So, how long do you think it will take in terms of the catch-up of cancer diagnosis and treatments? How long do you think we will see the impact of the pandemic on cancer survival rates and length of recovery time? Obviously, very important questions to a natural audience. I wonder if anyone wants to kind of build a little bit on some of their earlier statements or kind of insights in terms of the length of time we think it might take for this catch-up.
I think there's two aspects to this. Firstly is the impact of the direct event, and the runoff for the impact of that may be 5 to 10 years. You know, with people presenting later, it may take, you know, depending upon the aggressiveness of the cancer, type of cancer, you know, that long to run off. In the longer term, you know, the bigger impact is going to be on, for example, you know, what direct impact does COVID have on the risk of cancer? How has the services recovered to, you know, from the pandemic and the recession that seems to be coming, and you know, how's that going to you know, affect the outcomes?
Thanks very much, Chris. I think one salutary lesson from the webinar is the complexity and the difficulty in terms of understanding the different elements that we've been discussing certainly puts into perspective some of the prior seminars where we were talking about longevity in general. Just focusing down on cancer makes it clear how difficult it is to look forward into the future. I wonder if I might come to each of you in turn just for some kind of final closing thoughts as the kind of sands of time run out on us. Carrie, do you want to kind of start us off?
Sure. I think I feel a little bit split. I feel really positive about the developments in terms of new treatments, in terms of personalization, in terms of genetics, in terms of innovation in use of AI, which I think have real potential to increase early diagnosis and improve the quality and outcomes from treatment. But on the other hand, I feel very concerned that the system within all of this sits is feeling a little bit worn out and close to breaking point. And I'm worried that we won't have the resources economically and professionally to take advantage of those innovations.
Thank you, Kerry. That split view is very, very important and interesting. Thank you for sharing it. Chris?
I would just echo Caroline's view there, in that we're at an exciting time in terms of the development of the science and therapeutics, but this, they're only going to be as good as the organization within which it sits, and that is going to take a battering, I think, in the next 5 to 10 years.
Thanks, Chris. That battering is slightly worrying. Nicola, your final thoughts?
I'm going to just try and be a bit more optimistic. I know that the system is struggling, but I think let's not forget things like AI, incredible speed with which CT scans can possibly be read. So even an off itself, separate to the pandemic, if that's something that can be utilised more widely. There's plenty of pilot sites around the UK with amazing results showing us that unusual tiny lesions that were not possibly viewed by the human eye can now be identified and treatment offered much earlier to people. So yes, certainly the system is struggling, but we've also seen really innovative projects by groups within the NHS and how they're dealing with getting things back to normal now. So I'm just going to try and end it a bit more positively.
Thanks, Nicola. I appreciate all of you being balanced, positive, and kind of highlighting the challenges. Let me just say thank you very much to the three of you, to Caroline Chill, Chris Martin, and Nicola Oliver. I think everything you shared has been incredibly valuable and interesting. I'm sure there will be further questions that come out following this. I'd like to just bring this webinar to a close. I would highlight that there are a number of previous webinars which are on our website, so you can click those to see those different webinars. We are in the process of planning our next webinar in the series, so if you have any particular topics you'd like us to address, either at the general level or like today focusing down on a more specific area, namely cancer care, please do let us know. As I said, the recording will be available tomorrow, so that people either can look at it again or maybe look at the first time if they're unable to make today. And finally, let me thank you for coming to listen to today. With that, have a good rest of your day, and hopefully the next 5 years are more positive than maybe we may fear. Thank you very much. Bye for now.